Good morning, everyone. Welcome to the IV Update course. Today, I am going to talk about accountability, legal, and professional considerations. Target learning for this topic includes accountability, competence, consent and legal issues, documentation, and policies. So, what is accountability? Accountability, as defined by the NMC, is the principle that individuals and organizations are responsible for their actions and may be required to explain them to others. This means that you have a duty of care to your patients and clients who are entitled to receive safe and competent care. And when we are giving medications through IV or any other medications, registered healthcare professionals who administer medicines are accountable for their actions, non-actions, and omissions, and exercise professionalism and professional judgment at all times, as defined by the Royal Pharmaceutical Society. So, who are you accountable to? Firstly, you are accountable to your patients. As I have said a while ago, it is your duty of care to provide a safe and quality care to your patients, their family members, as well as their carers, and any breach or failure in that duty of care can lead to complaints, legal actions, or sometimes a referral to a professional regulator. You are also accountable to the public. Thirdly, you are accountable to your employer. So, when we were hired by this trust, we did sign a contract where it states our jobs, role, and responsibilities. This means that we should only practice and provide care to a reasonable standard in line with our trust policy and in line with our scope of practice. And we are expected to prepare, administer, and dispose IV medication safely and in line with our policies. In the event that the staff member is not working within this framework, then they will not be covered by the trust's vicarious liability. So, vicarious liability, in a sense, is the employer or our employer is accountable for our actions, provided that we are practicing within our scope of practice or competence and within the trust's policies. And fourthly, we are accountable to our profession. So, professional accountability means that all registered healthcare professionals are all required to have a live entry on a professional register. And for us registered nurses, that would be the NMC or the Nursing and Midwifery Council. The primary purpose of this professional regulator is to protect the public, and this is achieved by regulating the workforce. And we are required to work within the codes and standards that provides a professional framework to guide their practice. And through revalidation, our practice is assessed every 3 years. So, what does it mean to become competent? Competence comprises of having the knowledge-based practice, and that is achieved by attending the IV therapy full course. You should also have the necessary skills. That means that you should be assessed in practice, firstly, making sure that you have passed your theoretical assessment that includes drug calculation and a multiple choice question. And you should also have completed a designated number of supervised assessment with your assessor. Now, these skills includes preparing, administering, and disposing of your IV medications, which is supported by the relevant underpinning knowledge. And lastly, in order to maintain this competence, you should attend an IV update program, which should be done every 3 years in accordance with our trust policy. It is also beneficial that you have your practice assessed on a regular basis in order to provide evidence and assurance relating to your skills in IV additives. The principle of consent is an important part of medical ethics and international human rights law. Consent means that a person must give permission prior to receiving any type of treatment, tests, or examination, and this should always be done on the basis of an explanation by a healthcare professional or a clinician. For a consent to be valid, it must be voluntary, which means that the decision to consent or not to consent to a specific treatment should only be given by the person, which means that there should not be any influence of pressure by any member of the medical team, a family, or even friends. It must be informed, which means that all of the relevant information should be given to the patient, which includes the benefits and risks, any reasonable alternative treatments, and the consequences that can happen just in case the treatment does not go ahead. And lastly, the person should have the capacity, which means that they understand the information given to them, they are able to retain that information, and they are able to use that information to communicate the decision that they are going to make. So, according to the Mental Capacity Act of 2005, all adults are presumed to have sufficient capacity to decide on their own medical treatment unless there's significant evidence to suggest otherwise. A person may lack capacity if their mind is impaired or disturbed in some way, which means that they're unable to make a sound decision at that time. Some examples of this include a person of a mental health condition, dementia, severe learning disabilities, brain damage, for example, from a stroke or other brain injury, physical or mental conditions that cause confusion, drowsiness, or loss of consciousness, and intoxication caused by drugs or alcohol misuse. As capacity can sometimes change over time, it should be assessed at the time that the consent is required. In circumstances when an adult lacks the capacity to give consent, a decision about whether to go ahead with the treatment will need to be made by the healthcare professionals treating them, provided that it is on the best interest of the patient. Like adults, young people are presumed to have sufficient capacity to decide on their own medical treatment, unless there's significant evidence to suggest otherwise. They can consent to their own treatment if they're believed to have enough intelligence, competence, and understanding to fully appreciate what's involved in their treatment. This is known as being Gillick competent. Otherwise, someone with parental responsibility can consent for them. And they should also be a reminder that a person with that parental responsibility should also have the capacity to give consent. So, how is consent given? Consent can be given verbally. For example, a person saying they're happy to have their scan done. It can also be in writing, for example, signing a consent form for surgery. And someone can also give nonverbal consent as long as they understand the treatment or examination about to take place. For example, holding out an arm for a blood test or a blood pressure check. And we can also term this as what we call implied consent. To our trust consent policy, adult patients are entitled to refuse to any treatment provided that they have the necessary mental capacity to make such a decision. So, when a patient refuses treatment or withdraws consent, the healthcare professional should see the patient with a witness, a relative where possible, and give a clear explanation of the consequences of not being treated. If the patient continues to refuse after a full discussion of possible treatment options, this must be documented on the notes. If they have already signed a consent form but then changes their mind, the healthcare professional should also note this on the consent form. Many aspects of our care usually involves a close and often intimate contact with the patient. Indeed, many of our procedures are accompanied by discomfort and sometimes pain. So, health professionals should always be aware that the potential for an accusation of wrongdoing to a patient is very real if any of the following occurs. There is an application of any intentional or negligent physical force. Treatment and contact is usually threatened, implied, or takes place without the consent of the patient, and when the patient is kept in hospital without their express consent. Wrongdoings to this person requires intention and is expressed in three forms: assault, battery, and false imprisonment. The words assault and battery are often used and interchanged. However, in the eyes of the law, the two are very different. So, this is the definition of an assault. Assault is usually the fear or threat of an impending harm, and it can either be physical, verbal, or both. One example would be giving a patient an injection if the patient has not expressly given permission to receive the injection. This action can be interpreted by the patient as a threat to them. Battery, on the other hand, is an unlawful application of force or any unwanted touching without the consent of the patient. And using the example previously, if the nurse proceeds to inject or give that injection to the patient without their consent or against their will, the nurse may face a charge of battery. And lastly, false imprisonment. So, false imprisonment, it is the intentional unlawful confinement of a person against their will. It comes in many forms and does not require any physical restraint necessarily. And it usually happens when a patient is held involuntarily in a hospital, a nursing home, other health facility, or institution, or even in an ambulance. So, one example would be a doctor who authorizes a ward to be locked to stop a patient from wandering for his own safety. However, the doctor might be accused of false imprisonment on behalf of the other patients on that ward. These allegations are fairly easy to avoid if you just keep certain things in mind when working with patients and their families. Always obtain consent from a patient before initiating any treatment. This may be evidenced by a consent form when needed, or simply by just asking the patient if you can take his blood pressure, change the wound dressing, or even administer their medications. If a patient refuses treatment and there is no threat to his life or well being, do not force treatment. Notify those who need to be notified and document the refusal and the notifications. Never threaten a patient or a family member in any way or act in a rude manner toward the patient or family member. Never hold the patient down to force treatment or administer medication. And never threaten to hit a patient or family member or actually do so. Documentation. It goes without saying that if it's not written, it is not done. Good record keeping is a mark of a skilled and safe practitioner, which means that whatever medication we have given, whatever care or task we have provided to our patient, we should always document it. Bear in mind as well that record keeping is covered by our NMC Code of Conduct. All medicines administered should be documented completely and legibly. If in any case we cannot understand a medication written in the drug chart, we should always be able to challenge it and make sure that we confirm it before we give that medication. And it's always best practice to have a secondary role checker with you when we give your medications, especially your intravenous medicines and controlled drugs, and make sure that a second signatory is also documented in the drug chart. If you have any questions or clarifications, you can always refer back to some of the such policies and legislative frameworks.